we are going to discuss some other scenarios from the hepatobiliary system, and these scenarios are basically related to the pancreas. So, our first scenario related to the pancreas is a 70-year-old male patient presented with the chief complaint of severe itching, dark urine, and clay colored stool. These are the features of jaundice. The itching, the dark urine, and the clay colored stools are the features of the obstructive jaundice. He also feels discomfort or fullness in the epigastric region. On examination, the patient is deeply jaundiced and there is a globular swelling palpable in the hypochondrium, or we can say that there is a the painless there is painless palpable gallbladder in the right hypochondrium. As the patient is old, there is obstructive jaundice as there is epigastric discomfort, so we can suspect about some malignancy in this patient. Moving towards our second scenario, there is again a history of an old male who is smoker. First of all, the age is more. Second, the patient is smoker, he is diabetic, there is history of epigastric discomfort, he is giving history of dark urine, clay colored stool, and weight loss, which are features of obstructive jaundice, as well as weight loss is feature of any chronic disease. The patient, if the patient has any chronic disease, he will be giving history of weight loss from 2 months. He deny any history of acute sclerosing cholangitis, stone, or worm. On examination, yellow sclera, painless palpable gallbladder. In this scenario, first risk factor is age. Second, the patient is smoker. The patient is diabetic. He feels epigastric discomfort. He has obstructive jaundice. He has weight loss history, and his gallbladder is palpable but painless. So, our diagnosis will be about some malignancy, and the malignancy common in the epigastric region with the obstructive jaundice-like symptom is carcinoma head of pancreas. Moving towards, what are the two differential diagnoses of painless palpable gallbladder? What is the most likely diagnosis? State Courviesier law. How will you investigate and treat this patient? The two differential diagnoses are carcinoma head of pancreas and cholangiocarcinoma. But the most likely diagnosis is carcinoma head of pancreas. In the Why not the cholangiocarcinoma? Because in the cholangiocarcinoma, the patient will give history of in the cholangiocarcinoma, the patient will give history of stones or long-standing history of acute sclerosing cholangitis, or the patient will give history of worms and worms. In the cholangiocarcinoma there will be history of stone, because cholangiocarcinoma is the carcinoma of the CVD, and in the CVD carcinoma occur due to long-standing history of stone or worm infestation which cause CVD obstruction for a long time, or any sclerosing cholangitis. As in this scenario, the patient denies these symptoms like these, so our most likely diagnosis is carcinoma head of pancreas. So, what is Courviesier law? According to Courviesier law, if the patient in the Courviesier law, if the obstruction of the CBD occur due to stone, gallbladder will not be palpable. But if the obstruction occur due to any other reason like carcinoma and cholangiocarcinoma, then gallbladder will be distended and palpable. Why in the gallstone gallbladder is not palpable? Because in the gallstone there is history of recurrent and chronic cholecystitis. The patient suffers from recurrent and chronic cholecystitis, due to which fibrosis and stricture occur, and the gallbladder shrink in size, due to which it is not palpable. While in the carcinoma head of pancreas and the cholangiocarcinoma, gallbladder will be palpable. So our two differential diagnoses according to Courviesier law are carcinoma head of pancreas and cholangiocarcinoma. The investigation we can do are the LFTs. In LFTs, bilirubin will be raised and alkaline phosphatase will be raised, which will suggest the obstructive jaundice. The first initial modality is the ultrasound. Ultrasound will show us the stone, the dilatation of the proximal common bile duct, in the mass. It can also tell about the tumor mass. We can also do endoscopic ultrasound for tumor. Through endoscopic ultrasound, we can take biopsy. We can take FNAC, fine needle aspiration biopsy. Transduodenally or transgastric biopsy can also be taken through duodenal route, and through the stomach route. A biopsy can be taken through the endoscopic ultrasound, in which an endoscope is passed. The CT is the basically is the investigation of choice, because it will tell about the dilatation of the biliary, the level of obstruction, the site and the size of tumor, as well as if we do contrast enhanced CT. If we add contrast in the CD, it will tell about some more detail. That is, it will tell about the relation of the tumor with the vessel, with the veins, with the mesenteric artery, and these are basically the metastatic areas of the tumor. The tumor can involve the portal vein, the ciliary vein, the mesenteric artery, and can metastasize to the liver and lungs and the peritoneum. And these metastases can also be differentiated or seen by CT. We can also do MRI angiography for relation of tumor with vessel. We can do laparoscopy for peritoneal and hepatic metastasis. We can do CA 19-9, which is not very sensitive, not very specific, but it can help us to monitor the treatment response. If the patient is responding to the treatment, his CA 19-9 will decrease with time. Now, what are the treatment options? In 80% cases, the carcinoma head of pancreas has very worse prognosis. So when the patient present, he present in very advanced stage, and we do only palliative treatment. While in 20% cases, we do curative treatment. In curative treatment, we basically do whipple operation or whipple procedure. In whipple procedure, we resect some areas. In whipple procedure, we resect the common bile duct, we resect the gallbladder, we resect the whole duodenum, the pylorus and the antrum of the stomach, and the proximal end of the jejunum, as well as the lymph node near the pancreas. These are the areas dissected in the whipple procedure. That is CBD, that is pylorus and antrum, that is head and neck of pancreas along with tumor, duodenum, and proximal jejunum. These are resected, and the remaining part of the liver, the remaining part of the stomach, and the remaining part of the pancreas are connected to the jejunum through hepatico-jejunostomy, gastrojejunostomy, and pancreatico-jejunostomy. Here, the tumor along with the head and neck of pancreas remove, entire duodenum remove, proximal jejunum remove, lower end of the stomach, CBD, gallbladder, lymph node, and then to restore the continuity, we can do hepatico-jejunostomy, pancreatico-jejunostomy, and gastro-jejunostomy. Nowadays, a standard procedure, that is pylorus preserving pancreatico-jejunostomy, is done, in which basically the pylorus and the antrum are not resected, while all other organs which we have resected in the Whipple operation will be resected in this procedure too. Thank you. If you like my video, subscribe my channel and share my videos.